OK，那我们这样子开始。Let's start. I mean, my family is from Taiwan, but I grew up in the U.S., so I'm going to do this talk in English because, as I say to my family, my Chinese vocabulary stops at the 5th grade, so it's not going to be sufficient for for the talk. But it's really, really great to be here, and thank you so much for the organizers to invite me to speak. I'm a radiation oncologist, but I also lead a lot of immunotherapy development in the United States. And so I'm currently at the Cleveland Clinic, where I'm the chair of the department for immuno-oncology, which is, in our organization, it's a department which was designed to do a lot of experimental therapeutics and so forth to to promote clinical trials and also basic research. So what I'm going to talk about today is, as you know, as radiation oncologists, we live in a time when there's rapid changes in survival, right, for our patients in many different types of cancers. And so the goal of this is twofold. One is to discuss, to make sure that everybody here is aware of things that we need to be aware of in a multidisciplinary tumor board in precision oncology, all right, especially when it has to do with immunotherapy. And secondly, where we're going in terms of using the combination of immunotherapy and radiation therapy. As I'll show you some statistics, at least in the United States and Europe, there is a large proportion of trials being dedicated into understanding how to use multimodality therapy together to better control tumors. And as you have heard today from Dr. Lin and others out there in their excellent talks, there's a lot going on in terms of really increasing that survival that we previously thought would not be possible. So these are my disclosures. So I'm just going to discuss here very briefly the impact that immune checkpoint blockade has made in our practices, as well as for the lives of patients. Even as a single agent, there's market activity, as you know, all right? So as radiation oncologists, we see this in patients that are getting these types of therapies. And this is one patient from 2015. When I was at Memorial Sloan Kettering, a lot of immune checkpoint blockade agents were first tested there in the very first phase 1s. And this was a melanoma patient that received a single dose of IPI, which is anti-CTLA-4, and anti-PD-1, the combination together, single dose. And this patient was a patient of Paul Chapman, a friend of mine at the time on the melanoma service, and she had a big lesion, on the chest. All her disease disappeared completely after a single dose, which at the time, to me, I'm used to looking at meta-analyses and trying to figure out tiny little differences between survival. This type of change is really was very difficult to know. And of course, not everybody behaves like this, all right? Not everybody receives this type of benefit, but we do see an increasing number of patients are these exceptional responders. And this is a listing of all the different types of response rates that you can see with single agent anti-PD-1. These are overall response rates across different types of cancers. And so what we're seeing here really, as you know, is an activity that spans different types of cancers. We see a lot of activity across different diseases, irregardless of the site, suggesting that there are common mechanisms that allow tumor immunity to be evaded. So this is not obviously for you to pay attention to, other than just to impart that there's many indications in the United States now for anti-PD-1 therapy, which is really the dominant immunotherapy. Many more being tested, of course. As of last year, there were 18, but these approvals continue to be advanced in both the United States, Europe, and Asia. And in radiation oncology, I think that I give this lecture to radiation oncology audiences, and I always emphasize that this makes multimodality therapy even more important. Okay, it's not that it's one or the other, or, something's going to cure, this, and, you're not going to need surgery anymore. In the history of oncology, multimodality therapy has always shown to be very, very important. And this makes our jobs as radiation oncologists even more important. And the example I like to use at tumor board is you get antibiotics where the therapeutic ratio is amazing, right? But you never not drain an abscess, right? So it's a very similar concept here. What we really need to understand now is how and when to use radiation. Timings and combinations are critical right now for us to understand. Very, very much like the first coming of cisplatin, right? More than 2 or 3 decades ago, where we must really work out through the ensuing decades when and how to treat, what dose, concurrently, not concurrently, in series, and what agents, right? Variations depend on cancer types. The answer here is not so simple because the types of tumors here have very different contexts for tumor evasion, and molecular considerations for standards of care are improvement because not all patients are the same. It's a complex biology, and so the complex tests that we have to do to understand this. So what do we understand about these tests? Well, the approved biomarkers for immune checkpoint blockade, there are some, okay, which we'll go over just as a learning point. I'm sure many of you know about this already. Approved biomarkers for radiotherapy, none. But I would argue actually right now that there's a lot of potential for understanding combination radioimmunotherapies because in fact, these two types of therapies utilize and touch upon mechanisms that are very similar, okay? And we'll talk about that. And also combinations of radiation and checkpoint therapies are perhaps moving faster than how biomarkers can be developed for these. There are already standards of care right now, say for Pacific and lung cancer. It's an area of intense investigation. And so we really need to start, developing precision oncology approaches, moving forward. And so why do I say that radiation and immunotherapy really, have commonalities? Well, this is the tumor here, okay? So we know that the tumor no longer, we now know that the tumor doesn't exist by itself. It exists along with a lot of other different types of cells that either can control its ability to grow or to not to grow. And through a lot of work, including a lot from our lab, we know that the T cells, or the immune cells, interact and help control the tumor cells by recognizing tumor antigens. But in fact, radiation, what does it do? Well, it kills cells. It's a very potent stress response, and it actually increases not only cell kill and antigen availability, but also the ability of tumor cells that are intact to present those antigens. So it's very critical for, as a means of being able to essentially have an in situ vaccination. And the combination really is being taken advantage of, I think, in different clinical trials. RT can actually, stimulate, presentation of antigens for tumors. But on the other hand, RT is a double-edged sword, right? Because if you use it in an inappropriate time, amongst the most sensitive cells to radiation kill are cytotoxic T cells. So in my mind, it's never really made sense to have phase 3s that treat concurrent radiation and immune checkpoint blockade. We'll talk about why I think that is, but essentially, you're recruiting T cells into your tumor, and through the course of about 4 to 6 weeks, you're killing the TILs that come in the whole time, all right? That's why probably up to 4 head and neck trials have failed up to now. I think they were just not done in a very meaningful way. So a lot to learn from there. Molecularly, what happens? Well, we now know that with radiation, you make double-stranded breaks. You obviously have cell cycle control of killing, right? It kills tumors in G2M, of course, as you know from basic radiobiology, triggers DNA damage response. It's thought that cancers actually have loss of intact DNA damage repair, which causes an increased sensitivity, okay? But in essence, now in the last decade, we realized that both radiation and immune checkpoint therapy engage the immune system, and when done synergistically, we can actually boost this level of activity, perhaps even more important in solidifying what radiation therapy does after the treatment ends. So what do we know? What do you have to know for tumor board, at least in the United States and in Europe? Okay, so what are the the biomarkers that are United States FDA approved. I put the stars next to it, right? High tumor mutation burden, which is something we developed in our laboratory that then moved on later on. Neoantigen burden obviously is a reflection of what this TMB is. PD-L1 is still very important. PD-L1 is thought to recognize the so-called hot tumors. In my mind, PD-L1 is a very important biomarker, although many folks have obviously argued about the importance of it in different tumor types. It is important for things like lung cancer, but not important for things like, say, in other different types of cancers like melanoma. It is complicated, right? Because PD-L1 purportedly identifies tumors that are hot, and able to have T cells come in, but in fact, this is not a static quality. It is actually inducible. Radiation can increase PD-L1 levels, in fact, right? So we have to understand that PD-L1 is inducible, and hence a slice of time readout may not be the most perfect, biomarker, right? So, but in the United States, it is used, especially for lung cancer, because it does allow us to enrich for responders. Very exciting, MSI, other mutations actually can't, that are rare, like POL-E, POL-D, MSI, when they're mutated, can cause very high TMB and hence cause a lot of antigens to actually form. That you have to know about. These are so-called tumor agnostic approvals, which actually make it very important for you not to miss them in patients when they have it, because that could mean like a complete response versus terrible, right? So you have to be aware of that. And of course, there's other mutations or other factors here like microenvironment and innate immune system, which can tip scales both ways. We don't quite understand this. Interestingly enough, we work on phase 3 trials a lot, and I've had a chance to really look at accrual data from different parts of the world. Immunotherapy, in my mind, works really differently in different parts of the world, believe it or not. This is not a lot of public data. A lot of that is coming out now, but a lot of it depends, I think, on environment, microbiome, host adaptation in the environment, which we don't all quite understand yet. So much to learn. For those of you that don't know, have not seen what the pathology, what a PD-L1 assay looks like, right now they have nominal categories. Positive score less than 1 to 49, 50 of the general categories. It basically stains for different types of cells. Very importantly, there are many different types of antibodies, right, that are used, and also different scoring mechanisms. Merck has a combined positive score, which scores everything that's positive for PD-L1 positivity. Some of the other ones, like the BMS antibodies, with the Ventana assay only scores the tumor cells, so you have to pay attention. It becomes very complicated, unfortunately. So often, the molecular pathologist is actually my very good friend sometimes to make your way through some of these assays. There are well over several dozen of them now, depending on what assays you've used and what drug actually you use, whether it's from Merck, whether it's from some of the new ones from China, whether it's from AstraZeneca. Really depends on the assay. So we actually like to think about immunity like this, okay? So when you have successful immunity, you must have the T cell here attack the tumor cell. For the tumor cell actually to present the right antigens, here in the green box, which is necessary for sufficient for the required anti-tumor activity, which is the binding of the MHC, antigen, and TCR, you can have many things affect what this is being presented, including many mutations, but also you can have, if you have the right MHCs, right, your different backgrounds, in addition to, of course, your phenotype of the TCR. Many drugs obviously start affecting here. They awaken the T cell, but they can also, stimulate MHC presentation. So many of the combination vaccines, right, are designed actually to do just that. So a lot of different ways, and we like to think about this. You really need this green box here for activation of immunity. You can do that through radiation in part by increasing APM on this side. So this is some of our very first data on Keynote 001 back when we published, well, this work began in 2010 actually from our lab, when we were looking at Keynote-001, which is Merck's first Keytruda study happened to be in lung cancer. And we went ahead and sequenced these tumors, and this actually y-axis just shows how many mutations there are, and there's more mutations in the patients that actually do well, right? This is eventually was some of the first data that led to the TMB approval. You see the same thing in melanoma. In fact, these patients who have greater than 100 mutations that were treated with anti-CTLA-4, actually some of them are still doing great. This is incredibly durable. These patients were treated on the phase 1 of CTLA-4 in New York when I was there, so it was a long time ago. And obviously this was shown to be the case, validated by phase 3 studies, including one of them, Checkmate 227, which showed that in high TMB patients, Ipi and Nivo had much better outcomes. Because of crossover, actually, the final FDA approval was for PD-L1 alone. But in your, thinking about these things, you can actually, just take home that in the phase 3 study, you can see a markedly different benefit between high TMB and low TMB patients. So why is all this happening, right? Well, because of the neoantigen theory. Right? What's a neoantigen? Neoantigens are proteins that are normally presented by the immune system, right? So as you all know, our immune systems are constantly turning over antigens and presenting it to our T cells. Vaccines, right, to allow us to protect us, like COVID, like introduces, something so that the immune system sees it. These are antigens. Similarly, cancer, actually, from mutations, can prevent antigens that are very different. And these antigens then have T cells come and attack these. If you have a lot of these, right, then of course you build up immunity of your tumor. Your tumor no longer appears like it should be there. It appears foreign, right? That's your therapeutic index of immunotherapy. So what led to the FDA approval eventually is this prospective data that came out after our studies, which is 153, which showed that in high TMB patients, you have much, much better responses. Here they use just the cutoff here. So in the United States, this has accelerated approval. It's an area of, I don't know what you use here for sequencing, but there's a lot of competition in the United States for different assays. There are a lot of issues now with implementation of the cutoffs, right? So the cutoff of 10, which is what they use, 10 mutations per megabase, may not necessarily be the same in all the different assays. So you really want to be careful in terms of really defining, using your best judgment, depending on what assay your colleagues or your tumor board have ordered. But regardless, this is one reason why you can prescribe immunotherapies. Ultimately, you ask why this is, and this also is data from Keynote-001 showing that actually the best responders, which had a lot of TMB mutations, also have a lot of DNA damage repair mutations. These are the patients that are actually doing well. Actually, smokers actually do better in these cases. And it's very reminiscent of some of the other larger real-world studies that we've done. Here, this is a study of about almost 2,000 patients that we sequenced at Memorial showing DNA damage repair mutations of all sorts, including mismatch repair, homologous recombination, all being related to better outcomes with immunotherapy. Coincidentally, in these same tumor types, there's many mutations, not completely concurrently, which we found. We use the same database here to show that they sensitize to radiation as well. So, there's no simple formula here. These here are actually ATM mutations here, and BRCA2 mutations, which we know in some cases to sensitize to radiation alone. This is one case where there's a homozygous ATM mutation. The patient received very low dose radiation, essentially palliative doses, and had a complete response to all their tumors. So it's very uncanny that you really have these DNA damage repair mutations being powerful predictors of response in both cases. So, we're arguing actually now, this is something we look at very, very carefully in all the prospective trials that we work on now. I'm going to go ahead and talk about other things that have made it into the clinic. Mismatch repair, obviously, is, for those of you that don't know, is an inability to repair DNA. When you have mismatch repair, there's a lot of mismatches that happen, and they build up a ton of mutations. In colon cancer, this makes up about 15% of all colon cancers. It's mainly on the right side, less so on the left. Okay, and so Luis Diaz was a friend of mine, actually, working together. He ran this phase 1 trial and found that the mismatch repair mismatch repair positive tumors had very, very high mutation rate, okay? And they responded very, very well, irregardless of where the tumors are. And in sequencing, just to give you a TMB breakout of this, it's roughly 1,782 mutations on average for mismatch repair positive tumors. And these patients actually responded great. In Keynote 177, which was the first line phase 3 trial testing this concept, patients that had metastatic or locally advanced mismatch repair positive colon cancers did much better. This is now the standard of care. And so this is the summary of what you need to know, the current state right now of FDA approvals for genomics-based approvals for immunotherapy, right? So you have mismatch repair, okay? So you can give this for pembrolizumab, Nivo, Ipi-Nivo. These are all approved. DoStar actually was approved only last year, so you can add that on. I haven't put that on. So this is very high TMB. This is TMB greater than 10, which is arguably a lower threshold here for patients that have progressed on other types of tumors. And then the first line, MSI positive, FDA approved pembrolizumab for colon cancer, as I showed you from Keynote 177. There are a lot of things, a lot of excitement that's going on now. You may have seen this. It seems like in the mismatch repair setting, the anti-PD-1 is even more active in the neoadjuvant setting. So this is actually quite important because for those of you that treat GI cancers, this is very, very critical, all right, for you to discuss in tumor board. If you have a mismatch repair positive rectal cancer or colon cancer, you have to be very careful because these patients can have very, very good responses in the neoadjuvant setting to anti-PD-1. This was the NICHE-2 trial results that showed really an incredible response plot here, right? This was presented at ESMO a little while ago. This is a smaller study, 12 patients by Luis Diaz again, which showed in mismatch repair positive rectal cancer, you have a high rate of clinical CRs as well. Now, right now, it's unknown whether this is durable, so these patients may or may not continue to need radiation later on or surgery. They're being operated on right now, but it looks pretty good. And so, it's important to sort of tailor this neoadjuvant. Right now, of course, the treatment for this is neoadjuvant chemoradiation. You have to really tailor sort of depending on some of the mutation profiles that you find. So going forward, of course, there's many different trials. In 2021, I ran this analysis on all the different trials. There's 5,682 registered in the NIH database. Radiation combinations are one of the top 4 combinations with immunotherapy, right? So this is very, very active right now, much in lung, much in renal, much in GU cancers and other types of GI cancers and so forth. So very exciting times. All right, so how do we think about how to use immunotherapy and radiation, right? We see a lot of this stuff coming down the pipeline. Well, I separate it like so, neoadjuvant, before treatment, concurrent, and adjuvant. And these fall in the sort of concept of what I think as cooperative effects on site, right? I showed you earlier that immunotherapy and radiation both take advantage of genetic instability, both take advantage of sort of this non-self, right? This stuff is not supposed to be there, it's non-self, right? So it takes advantage of, these types of things and work together. Abscopal, which is something that has been, people have looked at, in our experience, is still extremely rare, right? After having been in the field for over 20 years, I'll tell you that I've seen one case of true abscopal in a pediatric patient with sarcoma, where the other side really disappeared. Other than that, I've really not seen it, and I've really tried to look for it too. So if you have really seen an abscopal effect, I suggest you publish it, because those are important, okay? It's just that, for all intents and purposes, I think for most of our patients, this is not something I'm looking for all the time. I'm actually looking for this. This is the biology, right, that really will affect most patients. So, be that as it may, I'm going to go over some of the rationale for combinations. Now, Steve Lin did a great job on presenting this. Pacific actually is a trial that looked at combination chemotherapy and radiation for locally advanced unresectable lung cancer. You know this, I'm not going to really go over it for too long, followed by adjuvant durvalumab, which is anti-PD-L1. It's a randomized phase 3 trial. A lot of these sites were open in Asia, of course, so it does represent, the community here. This is overall survival, which demonstrated a hazard ratio of 0.68, which is good. The 4-year update actually demonstrated durability of this response, both in overall survival and PFS. And actually, it turns out that, as I showed you before, the benefit actually transcends almost every single type of subgroup that we can see. And what this suggests is that when you combine chemotherapy or cytotoxics and immunotherapy, something else is happening, right? Individual biomarkers may not necessarily be so active. And so what we see here actually is a broad-based activity across multiple subgroups here. Some of these are underpowered, of course, but you get the general trend here from this plot. COAST actually is another trial, as Steve has already said. These are additional checkpoints, including one that abrogates the NKG2A NK cell inhibitory checkpoint with monalizumab. This is on top of durvalumab, right? And also oleclumab, which actually abrogates adenosine-induced immune evasion. And of course, you've seen this earlier where this has produced much better results. We fully expect COAST and Pacific 9, which is a phase 3 trial, testing this to show something similar. I'd be very, very surprised if this is not positive. And I know that the COAST is open in many parts in Asia as well. So we're very excited to see this and try to increase the benefit here. In esophageal cancer, right, you also see this combination taking into effect, okay? You see Checkmate 577, which is one example of a number of different trials where adjuvant nivolumab after standard of care chemoradiation, triple modality therapy, actually has produced a side effect. So again, you see the same thing, right? You see here chemo-RT, cytotoxics, potentially inducing some activity, surgery followed by consolidative nivolumab. So I think that in my mind, these are more reasonable studies because I think that just from mechanisms, as I was saying, it's probably beneficial to separate in time, the cytotoxic, immunostimulatory, and cytotoxic components here, and what I call the immune consolidation aspects. Okay, I don't think it's a good idea to do a trial of concurrent because, as you know, when you unleash nivolumab on the tumor, many of your anti-tumor cells come in and you're just killing them with radiation, right? So that's what I would suggest if you're gonna look at new trials. Head and neck, 4 negative trials, looking at concurrent, right? And yet the phase 2 adjuvant trials, of which we're involved in one part, met their endpoints. Okay, so we would, I would advise to go down that route. So the clinical questions, of course, is really who gets benefits, fractionation sequence, do we even have the right checkpoint agents, right? Nobody said that anti-PD-1 or PD-L1 was manna from heaven, right? I mean, this just happens to be one drug that people think works. But as you see in COAST, there's multiple different types of checkpoints that we may want to look at. CNS disease, which is what I treat, is very interesting, actually. We used to think that it was not safe to give these together, but we very rapidly learned that it's safe to give SRS and immune checkpoint therapy together. So if you have immune checkpoint patients that have received brain mets for those CNS folks that do treatment, I think in our experience, it's perfectly safe to give them concurrently. In the beginning, at our practice, we used to have these patients that would very quickly develop these big, what called hemorrhagic lesions, as I'll show you, in the next few slides, hemorrhagic lesions. I remember distinctly that I sent the first one or two of them. These were some of the very first patients getting IPI and SRS together. Sent them to actually my neurosurgery colleague, Phil Gutin at the time. He took them to the operating room. These things are full of T cells, actually. So we no longer do this, and we actually watch patients. And thankfully, we stopped doing that after about one or two patients. But this is some of the data that has come out from a variety of groups. If you give SRS and ICI, not only is it safe, right, these things disappear, but the CR rates tend to be better. What does the CR rate really mean in brain cancer? I don't know, right? A lot of times these things really stay steady, but for what it's worth, these things actually really disappear much sooner. So in practice, we really don't hold back the immunotherapy anymore. We just go ahead and have patients get treated. There are meta-analyses now that show potentially that local control may be even better for very recalcitrant recalcitrant disease types like melanoma, renal cell carcinoma, and so forth. This is an example of the SRS-induced inflammatory changes, right? So you can get this really big flare up in about even 30 to 50% of your patients. Do not send these patients actually to your neurosurgery colleagues. These very frequently resolve in and of themselves. There will be a question of whether you can give steroids or not. In our practice, we do give steroids, actually, and it really doesn't really impact the ultimate function of the success of the immunotherapy. Those immunotherapy patients still do pretty good. But obviously, the time of Decadron treatment, those types of things really remains to be worked out still. But still, I think to control this type of symptom, if there are symptoms, it's generally okay to give steroids. I'm going to go ahead and skip this because of time. Glioma is another instance where, again, timing, it's this consideration of timing being so important. Checkmate 153 was negative for the large part. This was a trial looking at nivolumab versus Bev, anti-VEGF for recurrent glioblastoma. There have been multiple phase 3 trials for glioma that are negative. And yet, so these are the different trials. But yet, in the neoadjuvant setting, at least with small numbers, it seems like there's an increase in responses, right? So I think we're reaching a time now, as you may see following the literature, that a lot of activity seems to be a little bit higher in the neoadjuvant setting. It'll be really interesting to see in a neoadjuvant setting whether immunotherapy response can actually be given then, followed by chemotherapy and radiation. Will be very interesting to see, and there are some small studies being launched to look at that. What is the mechanism when radiation and immunotherapy work together? That is an active area of investigation. Silvia Fermenti, actually a colleague of mine at Cornell, really has done some interesting work. She has shown that when you give IPI, anti-CTLA-4, and Nivo together with radiation, you can actually greatly stimulate those antigens that I told you about, neoantigens, which were not really detected with immunotherapy alone, suggesting that you have a combination of insults to the tumor, which can work together, and you can detect these in the blood. And in fact, these T cells are actually very active that are stimulated by these antigens in patients that have responses, right? So, I think it's very, very important to work out exactly who these patients are. These are relatively small numbers. But the good thing is, with all this information now coming out about potential mechanism, Big Pharma, a lot of your Big Pharma companies are very open actually to incorporating science behind a lot of the phase 3 clinical trials. So we've actually not been shy about proposing correlates which can ultimately identify who does better and who doesn't. Ultimately, I will say that with complex treatment and complex biology, an anti-tumor response is complex biology. What we understand is that where we're going to head likely is going to be someplace that's going to be similar to what we already do for breast cancer and prostate cancer where you have nomograms. It's not going to be a single biomarker for immunotherapy response. It's likely going to be, I am guessing, around 4 to 5 markers put together into a form of nomogram or something that we use similar to prostate cancer already, right? So it's not It's not Greek. It's not a foreign language. It's something that we use already, but it's likely going to head down that route. And we have done some initial work just trying to use machine learning to understand exactly what types of features really contribute a lot more to immunotherapy response. And we've developed some models, and this is just one slide here, which shows you how little we actually know. All right, so we took a lot of different variables from the clinical chart and built models that actually were pretty good, all right? And this is a breakdown. I mean, the model is not so important, right? These things go up and down. You can get better ones. The important thing here is that from the charts, we took out variables that were in an unbiased manner. We put in things like TMB, of course, tumor mutation load, a lot of these other things. And this is an unbiased machine learning quantification of how much these events, these variables contribute to response. And the other thing I'll note is that in our machine learning model, these are actually modeled to response, radiographic response, not survival, okay? A lot of things can affect survival, right? Fewer things can affect response. And so you have a lot of things here that really may affect immunologic health, but may not necessarily be reflected in stuff that we're looking at. Like, your level of albumin actually is really important in terms of how well you do with immunotherapy. So, we're working really hard to look at, a lot of prospective data to try to work this out. But I think this just goes to show you, at least in my mind, that the final story is still far from over. There's a lot of biology we learn. Interestingly enough, weight, BMI, can affect how well you do. Sex, which has been published already, right? So some of these factors validate what other people have found. I'm going to go ahead and there's only a few things I'm going to talk about. It's all about combinations now. As I said before, radiation therapy is one of the big four types of combinations that are put on top of a PD-1, PD-L1 blockade backbone for a lot of different trials now. This is just sort of a summary of all the different combinations that have been approved. When I started making this list about 10 years ago, these were all not approved, and now gradually you see all these things approved. I'll just make sure you have seen this, the Moderna, right, neoantigen-based vaccine in melanoma plus anti-PD-1 read out positive. Okay, so keep attention to that one, right? I think these tailored vaccines are going to, I think, really be exciting in the next 5 to 10 years. So very, very cool stuff there. All right, so challenges that remain. How do we sequence radiation in ICB? When new entities like vaccines pop up, how do we then sequence those? What diseases? Doesn't look like they're all the same. It looks like they're going to be different. So more work for us to do. Site of benefit. As I said, I think it really is a site of radiation versus abscopal, but of course that may be different depending on the oligometastatic setting, right? We have to really figure out what to do there. So I'm going to skip that. Acknowledgements, this is my laboratory, clinical collaborators. We're involved in supporting a lot of clinical trials at Cleveland Clinic. Cleveland Clinic actually has hospitals in many different parts of the world, so we're working to open trials on all the different sites, and yeah, this is my group. All right, that's it. Thank you. Any questions or? Yes, hi.
Hi, I'm Jenny Chen from National Taiwan University Hospital. Nice to meet you, Dr. Chan. You have a very wonderful speech. Thank you very much. I would like to ask you about, because most of us in the audience, we are radiation oncologists. Mm-hmm. So there's like our colleague, our other department is searching our collaboration. That's a abscopal effect. That means a very very low dose RT. That means like 0.5 gray per week, and like for 6 weeks. And so that is only to prime the M2 to M1 effect. So they are searching our collaboration. And because that's in the recent 5 years, there are collaboration between like SBRT and ICI, but most of them are like the effects are not so outstanding.
Right.
So now they are stretching like they are pointing out that if the RT we use very low dose like 0.5 gray or 1.5 gray for 5 days or for like for daily for 1 week. That is, the total dose is only like 7.5 gray or 10 gray, or like 1.5 gray per week on Monday usually, and for 6 weeks combined with ICI, and to pull the tumor microenvironment from M2 to M1. And do you think the hypothesis, will that work?
Yeah, I think there's a lot of work going on, and that's a great question. Probably the best advertised in the United States is from University of Pennsylvania, this RADVAC system. But low-dose radiation really, instead of killing the cells, really tends to be a stress response. And there's a lot of indication that may actually, that's all you need to actually stimulate the immune system. But my argument behind this is really one needs to think about testing, what dose is really necessary to try to achieve both, right? Because if you do a low dose radiation for an oligomets patient, why not just do a high dose, right? I mean, why not just, if you think about it, why not just take, like if it's 2 or 3 or 5 mets, why not just blast the thing and you get the control of the randomized trials that people have shown today earlier, right? So the important point is, I think, a frank discussion with the multidisciplinary tumor board on what the goals are, right? If it's an oligomets group of patient, you may want to go with a higher dose. Maybe just a little tickling dose may not be the right thing to do, right? Because you're giving up your above all, radiation for 100 years has been shown to be cytotoxic, right? I mean, it kills tumor cells, right? In a setting where I think it's very, very cold tumors, widely metastatic, and you want a vaccine-induced immunity, I think it's best done with more than one immune checkpoint blockade, right? So you have abrogation of local immunity, but you also have abrogation of more central immunity like anti-PD-L1. So I'd advise you to use 2 agents, anti-CTLA-4, anti-PD-1 together, and perhaps a little dose, in a small dose to immunostimulate as a radiation-based vaccine. So I think it's complicated, right? One would have to pick really the type of patient, do this, use the right agents, and only then use a smaller dose. Because my problem with the larger dose the smaller dose for everybody is you really, in a lot of cases, you give up the benefit of the cell killing part, right, which you could work in.
I think they are talking about the disseminated metastatic disease, and we only treat the little part, and their aim for RT is not to it's not for local control. It's only to prime the TME. I think their goal is like that.
Yeah, I think it's very reasonable for patients that are have widely disseminated disease. Yeah, absolutely. I think it's definitely worth something to try.
Yeah, so what's your threshold for like killing T cell? Is like a 0.5 gray or 1.5 gray? So what's your the threshold for killing the cytotoxic T cells?
The SF2 of T cells is actually very high, right? Even 2 gray SF2, even 2 gray will bring down T cells by an order of magnitude, right? By a log, as in 10% will survive. So. It has to be very little. I would not irradiate lymph nodes. So I think part of PORT, right? Part of PORT was that we were going around giving huge doses over 5 weeks to some of the areas where there's the most strong priming of the T cells, right? So I would not do there. But yeah, I mean, judiciously selected areas with low doses for those patients, I think is very reasonable. There's a lot of trials in the U.S. doing that, even with CAR Ts as well, as same problem, right? You want to make the local environment much more permissive. So irradiate, then add CAR T, and you can really see the CAR Ts move much more rapidly. So, yeah, hey.
Thank you. I'm Rodney from Chang'e Memorial Hospital. And have you ever looked at the C-gas sting pathway in your studies? Because many preclinical studies show that C-gas sting activation is critical for abscopal effect. And Sandra Di Maria's paper also showed that the responder has higher type 1 interferon beta. And do you have ever looked at the C-gas sting pathway?
We have. It's something that we keep in contact. We're not a CGAS specific laboratory, but we do keep track of this. Right now, I'll just tell you what some of the current thinking is, and you may have other thoughts on this, but the current thinking really is that it's a two-edged sword, right? So CGAS sting, on the one hand, actually, when you inhibit it, it can affect the immune system in one way at a certain time point. But chronic CGAS sting actually can suppress the immune system, right? And also, turn it the other way. Furthermore, CGAS sting has been associated with metastasis, boosting metastasis. In fact, there was a nice paper by Joanne Massaguet, I think only last month, showing that if you push it chronically the other way, you boost. So it's not a wonder. It's no surprise that the first CGAS sting inhibitors actually failed, right? I think that it was just throwing a drug on the wall, see what happens, right? But there's a lot more biology behind this, and it is something that we need to keep track of for sure, yeah. So, okay, thank you.